So, welcome to this inaugural lecture for Julia Bielicki. It's great to be here. I always enjoy these things and hearing about people's research. And it really is, it's a lovely opportunity when people do their inaugural lectures to hear about their life and their work. And so it's great to see you here. And also welcome to the people who are joining online. She said looking at the computer, not that anyone can see me, but I do that. As I'm sure you're all aware, Julia is part of the Centre for Neonatal and Paediatric Infection with her research interests across antibiotic use for neonates and children. And she really leads a very active group. She studied at the University of Cambridge, I understand being the top finalist in her year and winning the prize. And might be hearing about that later, maybe not. But she's been at what was St George's since 2012 and progressing and developing in her research and her research leadership since then. So I think, you know, I know that she enjoys thinking about the challenges in antibiotic treatment and apparently is also fascinated by the power of randomization. I don't know if we'll be hearing about that in the lecture, but I'm really looking forward to it. So it's great to see you all. Thank you all for coming, but I know who you're really here to listen to, so I'll hand over to Julia.
We're going to start with some disclaimers. I mean, I'm not going to talk to you about, you know, science in a way. I mean, yes, about science, but not in detail, but sort of sharing with you my journey and what I've learned from it. And of course, there are vast numbers of people to thank. Many of who you are here, you know who you are. So thank you. If you're not mentioned, it doesn't mean that you're not important. You're also very important. And some people will understand where this comes from, but there is a cartoon theme to this talk. I've left out villains. There have been villains, of course, and any good story, as you know, is only complete with a villain, but these are perhaps for another day and another lecture. So I need to go back a little bit. I'm not quite going to go back to Cambridge, although it was lovely there. But I'm going back to a year when actually my journey in infectious diseases began, and that's 2007, when I was working in an infectious diseases post at St Mary's Hospital. And I decided to leave the UK, rather saddened by the fact that I could not continue at St Mary's, to go to this lovely town, which is Zurich, to be with my now husband. Good decision. And I went to the Children's Hospital there to continue my training. And I had only done a few months at St Mary's Hospital, but as anyone who works clinically in pediatrics will realize, infections are absolutely everywhere in pediatrics. It's really the thing that preoccupies one's mind most of the time. And I started in a pediatric A&E, and on day 3 as a resident, I saw a child or a teenager, a 14-year-old girl who came with a fever and quite unwell and a non-blanching rash, which the clinicians in the room will immediately recognize as something that is not good. And the way that it works in Switzerland, which is not the way I was used from my then senior house officer training in the UK, is that you do not do anything without checking in with your seniors first, which in a pediatric A&E is actually pretty difficult because they're often quite busy. And to me, this looked like an emergency situation. So what did I do? Blood cultures, ceftriaxone, lumbar puncture, transfer to HDU, and voila, this is meningococcal meningitis. And I got this kind of mixed reaction from the senior staff in the A&E, because on the one hand, they were very impressed that someone was taking charge. On the other hand, they did mind a little bit that I hadn't checked in with them first. And obviously, so this is not only an infection, but this is an infection that responds extremely well to antibiotics if you identify it early. And there are countless stories to share about why antibiotics are amazing and why they are something that I then focused on. But I always like to share this very personal one. So this is my son, Paul, our son, when he was about 2.5 years old. And you will see that he has this swollen eye. This is another very typical pediatric infection. This is already in Basel. And 2 doses of coamoxicillin, and less than 24 hours later, you have a child who could not open their eye and looks like this. And I mean, it's really amazing. If you need antibiotics, they are like miracle drugs. And it was the same for this young lady with meningococcal meningitis. So I was like, okay, I mean, antibiotics and infections, I think this is where I want to go. But to engage in research, I really didn't have the tools to do that. So back to the roots. In 2009, we go back to London. And this institution, which is also one that I hold very dear to my heart, the London School of Hygiene and Tropical Medicine. And I mean, you can do a Master's of Public Health pretty much in lots of places. But this institution has this tradition of focusing on infections and global health. So they have these lovely kind of bronzes of vectors all around the building. So they're located here. And so, you know, this seemed like a really good fit. Also, it's a very prestigious institution and had offered a very interesting program. So that's me in 2010, halfway through my Master's of Public Health. So nearly there. And then I was like, okay, so now I have the tools, but where do I go to do this research? So it's a little bit like Alice in Wonderland, going down the rabbit hole. Oops, sorry. So where to find that inspiring person? Okay, off we go again. I don't know whether anyone recognizes this place, but this is Nice. And Nice is where Mike and I met for the first time. This is ESPID 2010, where Mike was having a very intensive conversation with a Swiss colleague of mine. And I was kind of lurking in the shadows behind some palm trees, going, okay, well, let's try and engage with Mike, because he seems to be engaged in some research that I would like to also be involved with, because, of course, by that time, Mike and Herman, who's also here, had started RPEC. So, and Mike is best described by the description of the genie, which is phenomenal cosmic powers, little living space, because he's always been at St. George's and always seems a bit too big. His personality seems a bit too big for everything that he engages with. And I mean, this issue of the humor mastery, which is particularly useful when you're in the confusions of antibiotic research, is also a very helpful trait. So this is, in fact, the project that I then became engaged with. This is the very first one that I worked on. I mean, one has to start somewhere. This is not very different from where I ended up, because it was mainly observational. And I was like, okay, I don't really, I mean, I know that this is interesting to me, but I don't know very much about it. And it seemed no one else knew a lot about it either. So we asked some questions about what antibiotics are used to treat children, what resistance patterns are seen, and we focused on children in Europe, which was a big enough bite to take as it was. And very soon after I met Mike, I met Tati, who's also here today. And Tati is the fairy godmother, and she makes everything happen. But she doesn't sympathize with those who are cruel or unforgiving towards others. And it is really true if you know her. She does not like that. And I mean, that statement, even miracles take a little time, is something that you could just hear a Tati say. So then, you know, we go, we find data, we find collaborators, we engage with them, and we work really hard. You know, there's like, I'm not going to go through all of those because there's stuff that came out of this, and we learned a lot about how antibiotics are used and what resistance patterns exist. And one of the things that we learned early on was that exposure in hospitals, so of children who are hospitalized, is high, in fact, slightly higher than in adults. And we also learned a lot about why antibiotics are used in children. This is data mainly from Europe. So you can see that there are, don't worry about the detail, but there are some things that are clearly very, very common, or a very common reason for antibiotics to be prescribed in hospital. And we will come back to that at a later stage, because that actually turned out to be quite important. And then we went on to do some more global work. And I mean, it's always interesting to me because in a lot of areas of global health, people say, yeah, what happens to people in the global south is really comparable to what happens to patients in the global north. And that might be true for some diseases that really are exclusive to those areas in the global south, but for antibiotics, it's not true. I mean, it's children are children, and really, whether you're a child in Africa or a child in the UK, you're going to have similar infections. Just the approach to managing them may be quite different. And this is when both, I think, Mike and me began to realize that the burden in terms of, you know, where people had difficulties of choosing the best antibiotics was actually highest in low and middle income countries. And I mean, I'm just highlighting here one antibiotic that is almost like an indicator for difficult to treat infections being very common. So you can see that in Africa, in Southeast Asia, and in the Pacific, which includes a lot of Asian countries as well, meropenem. So this sort of indication that people were struggling with managing infections, bacterial infections, that this was actually a very, very common antibiotic. And we also learned through sort of expanding on the RPEP work, the community antibiotic exposure is high too. So these are some data, some wholesale data that we analyze, where we're looking at how many units of antibiotics are consumed per person. And don't worry about the colors, don't worry about the exact data, but just look at the axis here, and you will see that 3 times as many child-appropriate formulation units are used both in middle and low-income country settings and in high-income countries as globally for everyone else. So meaning, you know, children really contribute considerably to the use of antibiotics, and because these are oral formulations, we know that most of this will be happening in the community. So what I learned was there's lots of antibiotics being used. Antibiotic resistance is a problem, so this comes back to the meropenem story, and apparently it isn't just a problem of sick adults in ICU with positive cultures, which is sometimes sort of the sound that you have in the background if you work in this area, and nobody really knows what to do in terms of treatment. And above all, keep it really simple, because, you know, working with all of these people, trying to get all of this data together, if you have a simple approach that is tried and tested and replicable, then that's the one that you might want to use. So I'm going to make a very, very small detour into a topic that is very dear to me, and that I'm also still pursuing as a sideline, going back to the London School of Hygiene and Tropical Medicine, because this is actually where I did my my PhD. And David isn't here today. Was my supervisor. He's a mathematician, and for David, the person that I sort of associate him with is Pasha. Pasha is this one. I'm the llama, just to be clear. So he's this very caring, very patient person who has to deal with this very unruly llama. If you know this film, you will know what I'm talking about. And he just keeps saying, everything comes together in the end, you'll see, which is a sentence that in this version or other versions I heard many times throughout the PhD. Because I was particularly interested in understanding how to use microbiology data to select early treatment. What I mean by this is treatment when you don't yet know what is causing the infection. And you have various kind of guidelines, including local guidelines that tell you what to use. So this is the current recommendation from the World Health Organization for childhood sepsis. Then, you know, this is the UK pediatric antimicrobial stewardship recommendation. You can see that there's already a lot more detail saying, you know, if you suspect this, then add that. If you think this is what is happening, then add something else. And NICE, so it's the body that sets guidelines in the UK, actually said that for all people, you should use existing local antimicrobial guidance, which, you know, I mean, I don't know what that means. I still don't know what that means, but this is what I wanted to investigate for my PhD. So I followed that principle of keep it simple, and I talked to David a lot, who is a mathematician, and we came up with a way of conceptualizing what you're seeing in your cultures and how you could use these data to make selections about treatment. So this is a decision tree. If there's any economists, they will recognize this. But essentially, you can then wrap the final output data from your microbiology, which is right at the end of your decision tree, back, and you can make some statements about coverage. And coverage is a concept that tells you whether your antibiotic regimen that you're using now has a high probability of treating the next patient with an infection that you see. So then we start working on this very complicated thing called weighted incidence syndromic combination antibiograms. And this has actually, for me, been the start of a long itch. So this is what they look like. These are actually RPEC data. And again, I don't want you to focus on the detail, but you can see that you can basically make comparisons between the coverage offered by different regimens by re-evaluating your microbiology data in a way that is different from what we typically do, where we look at bugs line by line. And you can also see that, you know, for some like meropenem and amoxicillin gentamicin, for those of you who work here, this is actually St. George's Hospital data. So Tim contributed this. You can see that the coverage offered by these two very different regimens is actually quite similar. So then we went on to try and explore this question of the coverage for these low and middle income countries. We focused on Asia. And you can see that what I just showed you for St. George's Hospital isn't the case, and that's true and getting worse, where this more traditional regimen, shown in dark green, really doesn't offer a comparable coverage to carbapenems. And this is when you can understand why they use carbapenems so commonly, because of course clinicians intuitively respond to this situation. And we go on playing around with these things. So this is actually a sidelight. So this is work that Aizen's led on, where we looked at Swiss data, grouping these coverage estimates, not by site, but by type of patient. And you find that actually this is a much more sensible way of doing it, because again, the neonate with community-acquired sepsis is more similar between the sites than they are similar to the neonate with hospital-acquired sepsis, for example. So we're still working on those. And what I learned from that is that actually clinicians, although they don't know how to capture this, care more about coverage than isolate susceptibility. Microbiologists, sorry, Tim, and researchers often don't. They're still quite fixated on that paradigm of looking at individual bugs. Nobody knows how to localize empiric regimens, as in how to take a guideline that is general and say, well, what do I need to tweak to make this more relevant to my setting? And there's a lot of bias and lack of precision in microbiology and surveillance data that nobody talks about. And this is something that's still true today. So, you know, this is influenced by who we believe should have a culture taken, for example. Or if you think of that St. George's data, if you have 70 isolates a year and they're different bugs, what are you going to say from that? I mean, everything can be by just a matter of a chance finding. So this is something that we're still struggling with. But anyway, so here we are. That's me in 2013. Yay. PhD plan is set. There's still 2 babies to come, but and I'm optimistically looking for my next challenge. Like, because sadness is really the companion to joy. You realize that maybe in research, not everything will be simple. So even during the MPH, I had some training around interventional research. I mean, it's very structured. It's not very operational. And the rules of engagement are part of the Masters of Public Health. So, you know, there's a lot of rules around interventional research. These are the rules for the battle between Merlin and MIM. No mineral or vegetable, no make-believe things, particularly pink dragons, no disappearing, and no cheating. Of course, MIM cheats. She becomes a dragon, but she points out that it's not a pink dragon, so that's okay. And I mean, this is really the infectious diseases doctor's dream of a film, because of course, Merlin beats MIM by turning into a germ, which is also in line still with the rules. I mean, it's bending them slightly, but he doesn't specify what germ, so it could still be a parasite, which maybe be an animal, at least not a vegetable or mineral. So, so you know, there you go. So we're thinking, well, I'm thinking, and Mike is thinking, we should maybe try and change that, what people do, and not just look at it. So we come back to these RPEC data, which are really, you know, were really the foundation for everything. And bacterial lower respiratory tract infections were the most commonly reported reason for prescribing. So it's like, okay, we want to do a trial in pneumonia. So then we come across Di. And Di is like Brahmatala. She's like the fount of all wisdom, yeah, but she has this kind of independence about her, and she collects all these valuable pieces of information and knowledge, but not just knowledge in intellectual terms, also knowledge about how to approach a problem or how to deal with a research question. And we sort of engage with Di, which was quite easy because, in fact, Mike and Di have been dancing together. Very different styles, you will know, but a very long time. And we submit a proposal for a randomized control trial to the NIHR. They actually funded too, which is obviously very pleasing. So we want to focus on pneumonia, we want to focus on dose and on duration of treatment. So this is me and Di. Di is always looking like this, saying, "Are you sure this is what you want to do?" But of course, you know, under her guidance, both me and Mike, I guess to an extent, we managed to make quite a good go of it. So in this trial called CAPID, we looked at some questions. Actually, for a first trial, we selected a rather complicated approach because it was a factorial trial, meaning that we investigated 2 different research questions. And we focused on the UK. We recruited, well, our colleagues in the UK through the Emergency Research Network, recruited here and in Ireland in 29 hospitals. And we managed to get all our kids into the trial just before COVID, of course, not knowing that COVID was going to come, but that was probably really quite lucky. And so, you know, we enrolled lots of children, and we randomized them in this factorial design. It's very simplified to receive either lower or higher dose for amoxicillin for 3 or 7 days. And we followed them up to check whether this worked. And we have another protagonist that sort of slipped in there, and he slipped in there in the way that he also is captured in my mind very quietly. From one of my mother's favorite Disney movies, who is quite monosyllabic and rather shy, but very deep thinking and kind. And I do like, this quote saying, look, why don't we play a game I know? Whoever is quietest for the longest time wins. And he would definitely win that with me, as I'm sure you will realize. So obviously, Wolfgang is behind these wonderful results. Again, don't focus on the detail, but we were able to show very convincingly that these 2 lines, both for the dose comparison and the duration comparison, they're really one line, meaning that there's no difference, that you could treat these children with just 3 days of amoxicillin, and in a setting such as the UK, also with a lower dose if that was aligning better with the formulations that you had available to you. And through Mike's connections to the Department of Health at the time, there were lovely viewpoints in our policy brief from Dame Sally Davis. So, she was saying that this is the type of trial that we need more of, which again was very pleasing, but we'll come to the sort of slight glitch in that in a second. So what I learned from CAPIT, apart from the fact that it had some very nice results, was that the pathway towards trial success is through a strong and trusting relationship with sites. Because, you can want to run trials all you like, but if you don't have people who back that idea, who say this research question is really important and we want to know the answer to it, you will not be successful with your trial. You can have a trial that can be very fancy, as in, this factorial design and everything, and inspirational, which it is. I love CAPIT, so it's a great trial, but it can still have some limitations that sort of go on to haunt you a little bit. And I think in terms of antibiotic trials, it's always a problem when you're trying to take something away. So unfortunately, this trial hasn't quite had the impact that I think it deserves to have, because what we're suggesting is that you could actually give less of something or give it for short, and that is really hard to implement. So clinicians don't like when you tell them do less of something. So then what next? So these are data for children in low and middle income countries, and you can see that actually pneumonia is quite an important disease there as well. So we're like, okay, we quite like to do something that is relevant to pneumonia in kids in African settings and Asian settings. And this niggling thing around the duration is sort of there. So we've got Sarah engaging at this stage. Edna Mode is one of my favorite characters, one of my favorite movies. And couldn't this just come from there? Far too busy. So ask me now before I can become sane. So obviously, Sarah has a knack of trying to improve how you can address questions. And so, this was an opportunity for us. And again, we were very fortunate that the funder agreed to try a different approach to investigate, especially the question around how long children should be treated for, which in CAPIT, maybe we approached in a more traditional way. Again, this is a very, very fancy design. It's quite complicated. You do know that Edna designs suits for superheroes. This is her thing. So there you go. You can basically do anything with this. It will tell you about oral step down. It will tell you which drug to use, and it will tell you how long to give everything for. So, it's really a very innovative and comprehensive way of dealing with this. So you can see that the descriptions of the trials become ever longer because the complexity of the trials also increases. And this is obviously a trial that could not have been performed without the support from all of our sites in Africa. And we had 13 African hospitals represented. And this trial, unfortunately, did collide with COVID. So we had to ask for an extension because COVID obviously had some very considerable impacts on pneumonia. So slightly larger this time. Again, the complexity increases. So you have this randomization for the key factorials of interest, what we use for changing from IV treatment to oral treatment and how long to treat for. And then you have this additional randomization, it's the same randomization, of course, but you have this additional benchmarking arm that actually turned out to be very useful, where you compare it against the standard recommended WHO treatment regimen, which may or may not be used, but it's at least a reference point that allows you to make some statements. And then again, we check whether these work. So like with Wolfgang, you know, there's always there's the statistical mind or the strategy, but there's someone who needs to do the legwork, and that's often quite hard work. So for this one, it's Michelle who worked with me and the whole team, who's very level-headed and cares greatly about her responsibilities, but probably again come from her mouth directly. Because you know, she was really stretched, I mean, in a good way, and she but it was, I think it was hard getting all of our heads wrapped around this chart. So these are just some very selective results. Again, don't worry about the detail, but essentially you can see that everything is comparable, which means that you can really simplify how you manage pneumonia in children. Because you can switch them to something that they can have by mouth rather than continuing them on IV treatment. And that means that they can go home earlier, which is, I mean, for anyone who's a parent, is a very critical aspect if you are in hospital with your child. So, I mean, I learned from Pedicap is really what I had already learned from Capit. I also learned that you need to give complicated trial designs the benefit of the doubt, because they often align with the research question. That's really important, to do the right trial that will actually answer your question and not just do a trial, which is going to be useful, but maybe not as useful as when you try and get that alignment. And actually, I'm more hopeful for Pedicap, even though it also sort of says do less of something, because it has that element in it that says, well, maybe do this instead of that. And that is going to be a much easier sell, I suspect, than just saying treat for shorter. But we will see whether that's true. So I'm just going to go very briefly through the last one, and I'm not going to say much about it because actually it's not completed yet. But you noticed before that neonates are also obviously a very big group that's affected by antimicrobial resistance, by bacterial infections, and therefore also by antibiotics. Receives a lot of antibiotic treatment, and sepsis is the key disease that is targeted. So, you know, then you're like, okay, so you feel really good about yourself with all of these trials that are very simple. You know, you've got pneumonia, it's quite a simple disease. And then, you know, you look at neonatal sepsis, and it's a bit like a bowl of spaghetti, because, you know, everyone does something, they change to all sorts of other things. There's no rhyme or reason. No one understands why it is people are doing what they're doing. But, you know, you've got Sarah, and Sarah is not scared of something that is a very changeable beast. So that's Jack, who is a baby. And Jack hasn't yet decided on his superpowers. So when he's sneezing, he's presenting all of them, but he's also looking at Edna and emulating her. So, you know, you can understand why she would be interested in neonatal sepsis too. So, you know, we're like, okay, we're gonna tackle this. So Auntie E has stayed up all night making sure you, Jack, look fabulous in your uniform, because obviously the uniform he has to have needs to accommodate all of these different things. So it is like a bowl of spaghettis. So we come up with a new design aligned with that question. And this is something that Mike and Sarah worked on together. And this is NeoSep, again, many of you in the room will recognize. It has a very different approach, which we're not going to go into, I'm not going to go into in detail at all. But you can see that you have lots of randomization options, and you have two randomizations trying to align with that spaghetti bowl picture that I showed you before. So this is currently working on, one of the projects we're currently working on. And it has a very different question, and so the design is really aligned with that question. And I mean, no talk would be complete without mentioning Louise. Louise and I have yet to complete a project with each other, but I am quite sure that we will do. Because Louise, of course, is like Mirabelle, who is a problem solver and always helping out and making sure that things run. And she's slightly insecure, Mirabelle, because she feels that she has no magical powers. She's born into a magical family, you see. But of course, she's the most powerful of them all. And I am sure that we will make this happen, because, you know, at the risk of repeating myself, Louise looks after the sites together with the whole team. And this, as you know, is the most critical aspect for any randomized controlled trial, no matter how simple or complex it is. So I'm sure that she, together with the CNPI and MRC CTU teams, will save this miracle, even if we don't quite know how to go through it yet. And for the rest, we will have to come back at some future dates to see what we find. So these are some of the projects. So NeoSep is one of them that we're currently working on. And really just like to thank everyone also who's listed here. There's many, many more. There's lots of projects that I've been working on with lots of people, lots of funders who've made this possible. But, you know, St. George's has really given me the opportunity to go from this to this. Elastical, holds everything together. And I'm going to leave you with another favorite of my cartoon characters, which is Dory, who has the best advice for the depths of antibiotic research, which is that you just have to keep going, and then you get